Hereby I open this academic ceremony in which Javier Castañeda Rojas will defend the academic thesis, Assessment of Automated Insulin Delivery and Continuous Glucose Monitoring Targets in Type 1 Diabetes Care. May I invite you to present a summary of your thesis, of your study and the conclusions of your thesis.
Dear Prorector, dear members of the Corona, dear supervisors, dear family, friends, and colleagues. It's a pleasure for me to present today a summary of my PhD thesis entitled Assessment of Automated Insulin Delivery and Continuous Glucose Monitoring Targets in Type 1 Diabetes. Every one of us, we do so many things throughout the day. We sleep, we wake up, we get ready for the day, and we work, we do exercise, we eat 3 times per day, sometimes more, sometimes less. We do all of this, and we do many more things throughout the day and the night. And normally, for a person that lives without diabetes, the blood glucose sugar, the blood glucose levels, that's the sugar in the blood, will remain rather stable throughout the day and the night, despite all of these activities we are doing. Unfortunately, for people living with type 1 diabetes, that is not the case. Type 1 diabetes is an autoimmune disorder that destroys the insulin-producing cells in the pancreas, and therefore there is absence of insulin, an important hormone that is needed to keep good control of blood glucose. So, after dinner, a person with type 1 diabetes will see their blood glucose levels rising. There is a risk of hyperglycemia. Or during exercise, blood glucose levels will drop down, and there could be risk of hypoglycemia. So maintaining good glycemic control with type 1 diabetes is very challenging, as we do so many activities, and these activities have an impact in blood glucose levels. Also, exposure to high levels of blood glucose during prolonged time will have an impact in the long term, affecting the health of the person with type 1 diabetes, some organs, and some parts of their body. That's why it's so important to have a treatment that allows to keep control of blood glucose. And all this started with the discovery of the life-saving discovery of insulin, the introduction of insulin pens, and also the possibility to manufacture insulin. These are the ingredients that make what is still to today the standard of care, the use of multiple daily injections. And this has helped millions of people, but it has also some limitations. Still, there will be swings up and down of blood glucose, despite all the help that multiple daily injections can provide. Technology has advanced, and currently, we have an alternative to the standard of care. This is the use of automated insulin delivery. As an analogy, let's think about a self-driving car. You want to go from point A to point B, you step in the car, and you activate the autopilot. This autopilot will assist you to get to point B to a greter extent. With automated insulin delivery, something similar is happening. This uses a blood glucose sensor that is measuring blood glucose levels continuously throughout the day and night. This data is being transmitted to an insulin pump that is equipped with sophisticated algorithms. These algorithms use the information from the sensor and also information provided by the person with diabetes so that the algorithm will make decisions, such as when to start insulin infusion, what amount of insulin is needed for that particular moment in the day, whatever activity you are doing, and also the decision to stop insulin delivery. What is the idea? To have a system that mimics closely the physiological release of insulin. People with type 1 diabetes can also use a glucose sensor, as I just mentioned. This sensor will be measuring blood glucose levels, normally every 5 or every 10 minutes. With this data, physicians and people with diabetes can monitor their blood glucose levels. And they can use the so-called continuous glucose monitoring outcomes and targets. As an example, one such target is time in range. Time in range, which is here depicted in color green, is the amount of time that blood glucose levels will fall in the range from 70 to 180 milligrams per deciliter. Clinical target is to spend more than 70% of the time with blood glucose levels falling within such range. There are also definitions for high blood glucose ranges, such as the time above 180 and 250 milligrams per deciliter. And for the lower extreme, there are definitions for ranges for blood glucose in the hypoglycemic range. Couple of examples. In one case, we have time in range of 100% of the time because the blood glucose levels, they fall in this range from 70 to 180. In the case below, 55% of is the time in range, and this is unfortunately rather common in type 1 diabetes. The remaining 45% of the time, the blood glucose levels will be either too high or too low. With this background, we assessed three main objectives in this thesis. The first one was to assess the long-term glycemic outcomes and their clinical trial conditions. The second, evaluate real-world CGM outcomes and predictors of outcome or improvement. And finally, inform the selection of appropriate continuous glucose monitoring outcomes and targets. For objective number one, we performed an experiment, a randomized controlled trial. So there were two groups that we compared. We compared the standard of care, which is the use of multiple daily injections of insulin. We compared it versus the use of automated insulin delivery for a period of 6 months. What this study has shown is that there is better glycemic control with automated insulin delivery. And here there is an example. When we look at time in range, there was an increase of 6.6 hours, additional hours per day in time in range with automated insulin delivery when compared with the standard of care. And there were more glycemic improvements. All of them, they were reached in a safe manner for the participants and with improved treatment satisfaction. We also had a continuation where we had 6 more additional months with automated insulin delivery. What this has shown is that the benefits that we observed in the first 6 months were maintained through time up to 12 months, providing evidence of longer term of good outcomes with the therapy. For objective number 2, we move from the well-controlled randomized trials to the real-world use of automated insulin delivery. And we wanted to identify what factors predict better outcome while in automated insulin delivery. In this case, we look at factors that will increase time in range, increase the number, the frequency of these blood glucose levels falling in this range. We observed 4 factors that would predict more time in range. One was the prolonged time in autopilot. The more time in autopilot, the better the time in range would be. The second one was appropriate pre-meal bolusing. So this is the insulin that you will require for your meals. As it is more appropriate, of course, you will have a better time in range. And these systems provide some settings that you can set yourself. And there are 2 of these settings that also predicted better glycemic control. One was a low glucose target. In this case, the lowest one was 100 milligrams per deciliter. And the second setting was a shorter active insulin time. In this case, the shorter one was 2 hours. Overall, for users of automated insulin delivery, the time in range would be around 75% of the time. But when these 4 optimal factors are being put into work, the time in range can increase to an average of 81% of the time with automated insulin delivery. Now, for a person that doesn't have diabetes, normally the blood glucose levels will be in a range from 70 to 140 milligrams, not 180. 180 is time in range, but for people without diabetes, it goes up to 140. So it's a more tighter range. And these glucose levels will be in this tighter range about 96% of the time. So it's believed that this is a more physiological range that could be used for the treatment and management of type 1 diabetes. Currently, there is no defined target for time in physiological range. We found that these same 4 factors will predict more time in physiological range, with the only difference that the impact of these factors is even larger in terms of predicting better physiological range rather than time in range. The time in physiological range, in average, is 47% normally, but again, when these 4 factors are being put into practice and in use, it could go to 57% of the time with automated insulin delivery. So it's reasonable to think that an achievable goal for time in normal glycemia or physiological glycemia will be more than 50% of the time. And now a door is opening to maybe start focusing attention into physiological range in type 1 diabetes. Moving on to the last objective. So far, we have seen quite a number of continuous glucose monitoring outcomes and targets. Time above 250, 180, time in range, time in physiological range, the 2 times for hypoglycemia, and now mean glucose. We ask ourselves, we have all these outcomes and all these targets. Are they associated to each other in some way? Are they related? And if so, how they are related? We found that continuous glucose, that glycemic control is composed of 2 main dimensions. One dimension is the normal glycemia dimension composed by mean glucose, time in range, time in physiological range, and the time in high blood glucose, in hyperglycemia. The second dimension is the dimension of hypoglycemia composed, of course, by measures of hypoglycemia, like time below 70 and 54. Something relevant here is that these 2 dimensions are rather disconnected or unrelated. That means that we can address and improve the normal glycemia dimension, and it doesn't mean that we are prohibited from also improving the hypoglycemia dimension. And automated insulin delivery can address both of these dimensions. Finally, this also suggests the possibility for simplification of continuous glucose monitoring outcomes. How? We select one representative metric from the normal glycemia dimension. We select another representative metric from the hypoglycemia dimension. So we have only 2 metrics. And with these 2, we will be able to reliably predict the other outcomes and if the targets are being met for those outcomes. Finally, both of these dimensions should be measure, monitor, and manage to capture complete glycemic control. With this, I would like to finish my presentation and give the word back to the prorector.
Thank you for your presentation. The opposition will be opened by Professor Brunner-La Rocca, Professor Cardiology and in particular heart failure at this university. Professor Brunner-La Rocca was also the chair of the assessment committee.
Well, thank you, dear prorector. Dear candidate, first of all, I actually would like to start congratulating you with a very nice thesis, very nice work that is really clinically relevant. Also a nice setup of the thesis, so that's really well done. And of course, I also would like to include your promotion team in this congratulations. And you actually nicely showed, well, how AID can optimize time in range. You also illustrated that very nicely. So the question actually to me is, well, is there a reason why any type 1 diabetes patient should not really receive AID.
Highly esteemed opponent, thank you for your comments and for your question. So, if we look from the point of view of outcomes, of glycemic outcomes, the argument can be made that, the better the glycemic outcomes, the better the health of the person with type 1 diabetes, maybe the reduction of long-term complications and so on. In that sense, maybe the answer is yes. Now, there is also something that we need to take into account. Maybe for some people, the use of this type of treatment is something that is difficult for them to accept. It's possible for some reason, psychological reason, or maybe at this moment I can also think about access. I know there are people that would really get a big benefit of it, but there is no access to this technology. So that's the way I would see it. It depends. If it's outcome, I think that the evidence is quite clear that automated insulin delivery really provides the best glycemic control compared with other treatments. So in that sense, the answer would be yes, but taking the personal, how each one interprets and manage their condition, that also deserves some space in terms of selecting the therapy.
Okay, just for my curiosity, what is the percentage of patients that actually receive AID currently?
Yeah, I don't have that number precisely, but if I make a rough estimation right now, there are 8.4 million people living with type 1 diabetes. And at least looking at the data that I am aware of, I would say that not even 1 million people will be having access to this therapy.
So there is still room for improvement.
There is a big need to increase access.
Yeah.
Yes.
Okay. No, that's fine. You actually mentioned an important point that I also would like to discuss with you. You mentioned health benefit, and you actually write on page 157 that the implementation of time in tight range, so time in range or time in tight range, may offer substantial health benefit. What do you mean by health benefit?
In connection to your previous question, you can think about also, again, I think that prevention of long-term complications is quite relevant in terms of health and quality of life.
I agree. You also write that you have shown that this in this thesis.
Yes.
But I couldn't find it really. Long-term complications or any other. Of course, you showed the long-term improvement of time in range of glucose control, but I didn't see any.
Yeah.
I mean, this is a number, and for patients, you could say, well, does it really matter for the patient?
Oh, okay. So, I mean, the time in tight range, it's been a metric that has been more. It's a rather modern or new metric, and there is now evidence coming out that time in tight range is a predictor of microvascular complications. Mm-hmm. So that is one of the sources to such a statement. So now there is a debate between time in range and time in tight range, because time in range also predicts some of these complications. Now, the data still needs to be, the evidence still needs to be there. Again, time in tight range is rather new, but there has been, at least to my awareness, a couple of studies that have shown that at least it can even predict the prevalence of diabetes, retinopathy, and nephropathy. And also, it can be used, time in tight range, as a diagnostic tool for diabetes type 1.
Mm. Well, even though I agree that there is an association between time in range and, complications, does that mean that if you achieve a better time in range, that you also improve clinical outcomes? Or I can tell you what my opinion is in that. The answer is no.
Okay.
Of course, it could be, but do we have any evidence that this is the case?
Yeah.
Probably not. So how would you actually design studies to actually answer this question? Because personally, I think it's very relevant.
It's very relevant, yeah.
For instance, in type 2 diabetes, we have quite some drugs that improve HbA1c, but don't improve outcome. We have drugs in hypertension that reduce blood pressure but don't improve outcome. So I don't think that you can say there should be or there is, per definition, a one-to-one correlation. So what kind of studies would you actually design?
So what comes to mind for me is the DCCT trial. So in this trial, actually, it was clear, the evidence, that a reduction in HbA1c of 0.5 is really predicting reduction of complications. Now, if I would be having the possibility to run a study for timing ranges, I think this would be something like that, like a DCCT study, where the follow-up, we're talking about decades of follow-up, where you really can connect outcome with complications. But again, this is not something so obvious and so easy to measure.
I agree. Of course, we are talking about lifespan, but may there be other possibilities or other kind of surrogates that you could use to actually study the impact on other organs or complications?
I think so, but I am not an expert in that type of...
Okay. Well, for instance, I mean, you could look at the kidneys. There are some studies showing, for instance, with SGLT2 inhibition. And, well, of course, I mean, you're actually showing, or you're also saying that the further development, you give quite some suggestions in that regard, but they're purely on the technology side. And personally, I think, well, the clinical side should be included as well, that you also could show what's really the benefit. And actually, I was quite surprised how little is studied in that regard. You actually mentioned one study in your discussion that really showed clinical outcome in patients with pregnancy or with type 1 diabetes, where you actually could show that. But I think that's something to add. And I'm happy with your answer, and I give the word back to the prorector.
Thank you. The opposition will be continued by Professor Brouwers, Professor Internal Medicine, in particular endocrinology and metabolic disorders at this university. Professor Brouwers was member of the assessment committee, and he is the secretary of this degree committee.
Thank you. So, dear candidate, I also would like to congratulate you with this very nice work. Also, congratulate your supervisory team on this. I would like to start with elaborating on chapter 3, in which you studied the determinants of time in range in this very large real-life cohort. And just to start off with a more, methodological question is, what struck me is that you started off with almost 17,000 individuals who had data uploaded in CareLink, and you end up with 3,000 for your main analysis. So I was just wondering, could there have been selection bias, and did you test that in any way?
Highly esteemed opponent, thank you for your question. Yes, the cohort, there were two cohorts, right? A cohort, and the main factor to define the two cohorts was the availability of baseline data.
Yeah.
Right? So the larger cohort was the cohort without baseline data. Now, we know that an important predictor of outcome is baseline status, right? So we really had to analyze that cohort, even though it was smaller. Now, we also thought about possible bias in selection, of course. And we actually fit 2 different models to see these predictors to both of these cohorts. And they provide us the same factors.
Yeah. Already going to interrupt you on that. So we're going to discuss that, whether they are the same or not. But first thing, if you just think of the population who had this pre-closed loop data, who are these people? I can think of who they are, but
yeah.
What do you think?
So
who are these people that did have pre-data?
Yes. It's I would say, a regional factor. Yeah. So there are some countries where part of the initiation of the therapy is a period of time where patients don't activate the automation, but they use sensors just to get used to the technology, also to the pump without having the automation, but they can start manually deciding when to have a bolus or some insulin.
Okay.
Yeah.
Could it also be, I just wondered that, because this is CareLink, so this is Medtronic, could it also have been that these patients already used an older pump of Medtronic and already uploaded data in CareLink with these previous pumps? And if so, could that have been influenced the outcomes or the determinants because they were perhaps already familiar with the Medtronic pumps and how they more or less worked? Of course, this was more fancy and more sophisticated, but still some things or items on the pump were similar. Could have that been?
So you mean that they are experienced with the technology before?
From Medtronic, yes.
I think it's possible in some cases that could be the case. Yeah.
And I think you gave a good answer with regard to the comparison with the overall cohort and the smaller cohort that you say, well, we did the analysis and we saw the same determinants. The only thing what I missed, unluckily, is in supplementary table 1, because that's, I think, you're referring to, where you do the comparison. You only mention p-values, and unfortunately, you don't mention any effect sizes of this univariate analysis, if I'm correct. So you're not really able to compare whether the strength of the associations in the overall cohort and this smaller cohort are really the same. It is statistically significant or not, that is the same. But I don't see any effect sizes, so no betas.
Yeah.
So that's a little bit unfortunate to really allow a comparison whether it's truly the same.
Yeah. You're right. This should be in the table.
Okay. Yeah. Okay. But you did a comparison. I think that's what you did very well.
And we of course look at the estimates, treatment effects estimates, confidence intervals.
Yes.
Looks pretty similar.
Okay. That's what you recall. No, it's fine with me. Yes. It's fine with me. Yeah. So the other thing what I wondered was, and that was in the results on page 53, you talk something about the observation period, and that was 112 and the standard deviation 69 days, so quite some variance. So I'm a little bit struggling with that because there is a follow-up period. So how did you deal with that follow-up period? So, for example, you talk about time and range in the follow-up, but is that the 1 day time and range, the 30-day, the 90 days? What is it actually?
Yes, this is the full period time and range.
The full period that you had of that patient?
Yes.
Okay. And should you have adjusted for the follow-up time? Because I can imagine that if you have a very short follow-up time, the patient is not really aware of all the tips, all the tricks of that new pump, and that affects the determinants of the time and range, or not? So should you have corrected for the follow-up period, I wondered?
Okay, several points there. The median follow-up was almost 100 days. So it's a pretty extended period of follow-up. Now, there could be some cases with less, because the criteria was to have at least 10 days with continuous glucose monitoring. So, in theory, it could be the minimum 10 days. I think that the way to approach that would be a longitudinal analysis, where you look at from initiation of automation, month 1, 2, 3, 4, 5. Yeah. So that research is not in this thesis, but we have performed that research. It's already published, and it has shown that the improvement with automated insulin delivery is immediate.
Okay.
You start with the therapy, in week 2, you get the outcome.
Okay.
And this is sustained. We have performed the analysis up to 3 years' time. Now, it slightly decreases the time in range by year 3, but it's a reduction of 2 absolute percent points. So it's not really clinically significant.
Okay. So you experience with other analysis that the follow-up time doesn't matter that much. That's what your conclusion is.
The way I interpreted your question is the benefit, because we are talking about a time in range, right?
Yes.
And the benefit is seen if you observe the first month or even up to 3 years. That's the evidence right now.
Okay. And finally, I wondered, so then you make these multivariate models, and what you did is whether or not a variable was included in the model, and this multivariate model was based on significance and strengths of associations. Well, that could be a strategy, but I was just wondering, what was the purpose of the model? Was that what you normally do when you do multivariable analysis? You have either an etiological model that you want to understand causes. Of course, you cannot do causal inference with observational data, but you think about causes. Or you would like to do a predictive model that you just want to predict with whatever, whether it's causal or not, how it affects outcome. So what was your purpose when you performed the analysis? Because well, depending on what your cause is, it determines how you decide which factors you should include in the model.
Right. So these were all retrospective analysis, right? Mm-hmm. So they are limited in
always.
Exactly. So, but we wanted to be able to understand factors. First of all, to have an explanation out of these factors, for example.
That sounds etiological.
Right, but for example, there are 4 factors that were predicting time in range, right? And the objective was to estimate the effect of these factors. Now, we used two modeling strategies. One, it was the traditional based on statistical significance, but there are also, we perform lasso regression.
I saw that, and exactly. Then you saw the same. But if we talk about, and that's my final remark or question, if you talk about the etiological model, for example, number of alarms per day, you included that in the model. And that was a significant contributor to time and range. So what happens if I just turn off the alarms, because then I don't have any alarms anymore, and then it gets better. Right. What do you think will that happen?
Right. So we discussed that, and what is the cause and what is the effect, right? In this case, so there is a scenario where your condition is not good and you have a lot of alarms. So what is causing what in this case? I would say that is your condition that is causing a lot of alerts. It's not because the alerts, your condition is worse. In that sense, I think that we have, not from the data itself, but from the knowledge of the disease and how the technology works, we can say that there is a direction, even though the data, the way it was collected, was not collected in such a way to have such a statement. But we can make some suggestions on what is the mechanism behind.
Okay. I'm very satisfied with the answers you gave me. I give the word back to the prorector.
Thank you. The opposition will be continued by Professor Nørgaard, Chair of the Clinical Diabetes Technology Institute in Copenhagen. Professor Nørgaard was also member of the assessment committee.
Thank you. Dear candidate, dear colleagues, I want initially to say that the studies in this thesis are really relevant for how we as clinicians are working with Minimed 780G. So I want to congratulate you and the whole team. So I want to maybe explore a little bit of the same as opponent number 2 about the prediction and how you so to say, use the data you have in paper in chapter 3 and 4 about the time in range and time in tight range and what predicts that. I understand statistically you can call it predictors, But honestly, it is more associations. Do you agree that we should be quite clear that those patients who have a 2-hour active insulin time and a target of 100, they are maybe different from those who have other settings. Maybe they are not those who eat one box of candy, or maybe it's not those who bolus too late or forget to set the temp target if they are exercising. So what comment do you have on that?
Highly esteemed opponent, thank you for your comments and your question. I agree with you. This is retrospective data, and these are the limitations that are possible. So regarding the use of the settings, yeah, I think that regarding the question before, that's where we maybe may have even more a kind of bias, maybe, but there is no really way for us with the data to assess that. But indeed, maybe there are some differences between those that use an active insulin time of 2 hours and a glucose target of 100 milligrams per deciliter. Maybe these are users of the system that are confident. There is also a psychological part with the use of these settings, and that's possible. Yeah, I have to agree with that statement. And the retrospective data is not going to give us a lot of room for us to decide on causality with this. Other type of studies may be more appropriate to close the discussion and see if causality is there. Yeah.
I wonder if you're in this CareLink database with more than 100,000 patients having uploaded, whether you can find patients who have other settings and you can evaluate their time in range, and then they have changed to the, so to say, the optimal settings, and then look at that. Wouldn't that be a good way of doing a prospective study?
Yes, that's a very accurate comment. And we have performed that analysis where for the same user, there are kind of periods in the use of the technology where users go for one setting, stay in that setting for a period of time, then they change, and for some reason they come back. So we have compared, this is with inpatient comparison, and the outcomes are very similar to what we have in the paper for the predictive factors. But again, this is retrospective data. There are some limitations, but at least to the extent of this real-world data, I think also the analysis that you have suggested is something we have done, and we have presented in some conferences, and it shows that even for the same individual, when they switch from one setting to another, the improvements in blood glucose, they have been observed. Yeah.
Oh, great. And you should publish that. It's also what the clinical practice, so to say, tell us, but it would be really a good add-on for clinicians to understand how important the settings are. So, yes. Good. Let me turn on to another topic. You have, in your great ADAPT study, prolongation shown long-term outcome. But 12 months, in my opinion, is not really long-term. I mean, we have had the 780G for 4 years now. So couldn't you, in your CareLink database, also look a little bit into time in range and how the 4-year data looks like?
Yes, thank you for your comment. Indeed, so 12 months follow-up is not necessarily the most longer term use that you can think of. I agree with that. And we also have been making use of CareLink data. And actually, this data has been published for the 3 years follow-up. This is in connection to the previous question, where the improvements are seen immediately, and they are sustained up to three years. But there is a slightly decrease in the timing range at 3 years, but not really clinically relevant.
It might maybe also be related to whether it's an observational CareLink study or a clinical study as the ADAPT follow-up, or what do you think?
Right, again, yeah, these are all retrospective analyses, and well, there are limitations, right, in terms of resources to conduct through clinical study up to 3 years, and maybe we can think of some registries, right? Like in the Nordics, they really can collect very robust data. That could be a good source for such other angle to look at the data. Yeah.
Also, as the first opponent, we discussed about the long-term complications for micro and macrovascular complications. We could use this in connection with the registries to look into that.
Right.
Good. I have another topic I want to discuss with you. You describe a little bit, I don't remember exactly where it is, a little bit of a mismatch between time in range and hemoglobin A1C. We would expect if people have 70% time in range, then hemoglobin A1C would be 7%, and sometimes it's not quite there, as for example in the ADAPT study. So do you think that this could be related to what some researchers have suggested recently, that the Medtronic sensor are measuring higher time in range compared to other sensors? Do you have any opinion on these discussions, rumors?
Yeah, maybe I have 2 points of view. One is more statistical than the other. So the statistical point of view is that the kind of association that has been tried, I think that time in range is not A1C, first of all. They are really measuring something different. And even though there is a strong correlation, when you try to explain one using the other, so for example, for an HbA1c of 7%, you can have time in ranges that really are very different. From 40 up to 80%. So the variability there is big. And that means that they are not really telling the same or the same story. That's from one side. The other is that, yeah, in ADAPT, we found that discrepancy between A1C and time in range in a particular direction. Now, more recently, we have published also the LENI study. So this was in pediatric population. And actually, we saw a little bit the opposite direction. I have seen some papers also that have been collecting. I think in one of the papers that I have seen, they compare 4 studies. Can I make a conclusion out of these 4 studies that there is a consistent, robust direction? I think that that's not, that's some evidence, but the uncertainty around that is too big to make a conclusion. So this is kind of my opinion. I don't think that there is something really regarding the type of sensor, because we have conducted, and the different studies have been conducted with different sensors, and this mismatch is also observed, not in one particular direction. So I think that there is still quite a lot of uncertainty to make a conclusion out of it.
Thank you. It's a great answer, and I agree completely with you here. So I think I used my time and want to give the word back to the pro-rector.
We have indeed to continue, and we will continue with Dr. Koster, Associate Professor in Lifestyle Epidemiology at this university. Dr. Koster was also a member of the assessment committee.
Thank you. Dear candidate, I also would like to congratulate you with this very good work, and I also extend my wishes, of course, to your supervisory team. I would like to start with some questions about Chapter 8. In this chapter, you provide insights in how you use real-world data and its potential for generating real-world evidence. And my first question is, in the introduction on page 129, you write, and I quote, "To establish trust in real-world evidence from CareLink Personal, we show that this database and the analysis strictly adhere to the principles of real-world evidence." And my question is, what does the word trust refer to? Does it refer to trust by the patients, by the researchers, the clinicians, or society as a whole? Can you elaborate a little bit on that?
Esteemed opponent, thank you for your comments and your question. So trust here is not connected to any kind of statistical or medical type of definition. So I would say that in technology in diabetes, we have seen in the last 5 to 7 years a lot of publications that in the title you see real-world evidence. And sometimes we have seen real-world evidence out of 15 participants. That is one level of trust, right? Should I just trust this and make an extrapolation to the whole population? That's one degree.
The trust that you have as a researcher.
As a researcher, as a reader, as a payer.
Okay.
This evidence is being used by physicians, but also by payers, right? And this is in connection to one of the previous questions about access to the technology.
Yeah.
So we need to be able to provide real-world data that gives this trust to all these different audiences, right? Yeah. And this is, we believe, is important to provide access to therapy that we believe will make a difference in the life of people with type 1 diabetes.
Okay, thank you. I understand, yeah.
Okay.
And I think an important step there is that the patient gives informed consent to that the data can be used. Yeah. And you write that the patients do that. Is that an opt-in or opt-out procedure on what you ask?
Right. So when somebody opens an account with it's called CareLink, they will start a therapy. So they can open an account with this system, and they are being asked, do you consent for your data to be used for research? And then you can say yes or not.
Okay, yeah, thank you. Yeah. And then I think in your chapter you write that the data can be used by Medtronic, but is the data indeed, do the patients give informed consent for Medtronic to use the data, or do they give informed consent for the research community, for example, as a whole, to have access to the data?
Well, the way we have been using is for Medtronic.
Okay, and what do you think of that? Should it be accessible for others?
There is a degree of access that I think is possible. Mm-hmm. Now, we are talking about companies that have intellectual property, right? So there is a degree of granularity in the data that needs to be considered. Sure. In such case, like if you go to very granular level of data, you would be able to reverse engineering some of the algorithms that have been are the main elements of some technology. So I think that this is possible, sharing data, but we always need to consider this granularity.
Yeah. And does, when the patient gives their consent that the data can be used, are you also allowed then to link to other data sources, like medical records or any other source?
Absolutely. They are owners of their data, and it can be used by them in the way they want to use.
Okay, yeah. Then a bit more a general question about the use of such databases in comparison to clinical trials and in comparison to other observational research, for example. For what type of research would you actually not use the real-world evidence data, but rather use clinical trials or observational research? When would you use what, in other words? Right.
So there are degrees of evidence, right? And I think that depending on the degree of evidence that you are looking for, you need to design the appropriate study. Well, this is actually changing, but usually to get approval of a therapy, you either, well, in the US, you go to the FDA and you have to run a study. Sometimes the FDA will accept single-arm studies. They have limitations. Now, in Europe, it's slightly different. Actually, it's a little bit more stringent in some occasions, where they really want to see a randomized control trial. So, in terms of evidence, I think that there's this first level of randomized control trials and then meta-analysis of randomized control trials for the highest level of evidence. Now, it also has limitations, right? How do I translate this from a control experiment to the actual use out there in real world. And I think that that's where there is a space for this type of analysis.
But if I link back to the previous question of Professor Bruno La Rocca, where he said maybe we should look at the long-term health effects of these therapies, for example, would you use this data that you have and link it to medical records or other registries, or would you set up a new study if you had a choice?
Okay, I need to consider the limitations, right? Like resources. Well, sometimes it's prohibited because of the resources needed, but there are actually several centers that are collaborating with Medtronic, where Medtronic provides this data. They connect this data with their medical history and records, and they are analyzing that data and bringing evidence. So that's, of course, that's actually the next level to what is in the thesis, because in the thesis we are concentrating to device data. Yep. But when you are able to connect with data from the clinic, and we have done also that with a clinic in the Netherlands, Diabetes, of course, now you can talk about weight, for example. We don't have weight in our device data. We can go much more in detail. So indeed, that's a good alternative. Yeah.
Okay, thank you for your answers, and I give the word back to the prorector.
Thank you.
Thank you. The opposition will be continued by Dr. Meyer, Associate Professor Internal Medicine at the Radboud University. Dr. Meyer was also a member of the assessment committee.
Thank you very much, Mr. Prorector. Dear candidates, let me start out by congratulating you on your very nice thesis. It was a joy to read, and when I received the booklet itself, it was also very nice to see the cover that you created yourself. And I wanted to ask you something about chapter 6, because there you are evaluating the coefficient of variation as a marker of glycemic variability and hypoglycemia risk. And well, given that the threshold for the coefficient of variation is often used as 36%, but that is derived from a population that doesn't use an AID system, to what extent do you consider the coefficient of variation to remain valid and meaningful in an AID population?
Esteemed opponent, thank you for your comments and your question. Indeed, so what we have seen is that automated insulin delivery reduces variability in outcome. Not only with our studies, but studies conducted by other groups. And so, when we say reduction of variability, that is not just variability reduction, but also improvement in glycemic values. So the two factors that compose the coefficient of variation, they both are improving. And by coincidence or by design, that's something that I don't know, the reduction has been almost the same, around 10%, the improvement in the reduction of variability and in mean glucose. So, well, I don't have the data to give you an answer, but what I believe is that as there is less operator variability, when a person with diabetes needs to make all these decisions, right, throughout the day, I'm going to eat, I'm going to exercise, I need this amount of insulin, but, you know, I have a thesis defense, so I am stressed. That also, that has an impact on how much insulin you would need. So the operator side is very important. You have also the physician, you have also the nurses, your family. There is a lot of variability that for exactly the same condition, the same activity, you may end up giving more insulin or less. So automated insulin delivery...
So let me stop you right there.
Yes.
Do you then think that the, well, a measure of variability, which would be different from the coefficient of variation, should be context specific? For example, during exercise, during or after a meal, do you think that might be a better way to gauge the results of an AID system?
I would say that we need to focus on what metric of variability to use, not to have. One of my statements is that there are so many continuous glucose monitoring targets and outcomes. Adding more levels, I think that's not going to make the path more clear. So I would say that specifically for automated insulin delivery, the coefficient of variation is their interpretation and utility is less. If I would have to select one measure, I would have to tell you, let's look at two, the mean and the standard deviation. Those two should be looked at because you can have a coefficient of variation.
But the coefficient of variation is a combination of those two markers that you just mentioned.
Right. I prepared an example for this question. So let's imagine that you have a mean glucose of 175 milligrams per deciliter and a very small standard deviation. So in that case, your coefficient of variation will be very small. But if you have a better glycemic outcome, let's say 110 milligrams per deciliter, and even 3-4 times the same variability, that might be a better place to be than close to 180. So I think that there is, in some cases, there could be a misconception of what the coefficient of variation is and when to apply it. If I would have to compare the variability of pediatric type 1 patients with adults with type 2, I would start thinking about the coefficient of variation. But in some contexts, these comparisons are really not bringing a value.
Yeah. I also have another question. Thank you for this answer. But to what extent are your findings regarding time in range, time in tight range, glycemic variability, and its independence of hypoglycemia, to what degree are they generalizable to other automated insulin delivery systems that use different sorts of algorithms?
Yeah, okay. Maybe one comment before that, answering your question. I think that conclusion might not be applicable for multiple daily injections. Let's say that because, again, automated insulin delivery is reducing variability while improving average glucose. So the literature shows that different systems have different outcomes. Now, that has to be seen with a lens and carefully looked at because the patient selection has an impact on these outcomes. So it cannot be just directly compared, and even with real-world data, that's one of the limitations. And if you try to compare those results, you may always have the risk of being blinded to an important part of the therapy. So a head-to-head randomized control trial is the one option to go if you really want to compare systems. Now, in terms of the simplification of continuous glucose monitoring metrics in these two dimensions, well, we don't have any study using multiple devices, but I believe that AID as a technology can really provide this simplification here, even for other type of devices in AID. Yeah.
So what you're basically saying is that your results are not generalizable at the moment to other systems.
No, what I'm saying is that the results are generalizable between systems in AID. But this, I believe it's not really generalizable to, for example, multiple daily injections of insulin and finger pricks, which is the standard of care in many places in the world. I wouldn't say that you can just simply select one outcome from the normal glycemia dimension and one from hypoglycemia, and you will accurately predict the other outcomes, not because there is such variability, again, with multiple daily injections that I couldn't say that you can just translate these into that. But for automated insulin delivery, they are.
You may finish your answer when you like.
Yeah. So for automated insulin delivery, when we compare publications, we have also real-world data publications and randomized control trials. The evidence is showing that overall, for automated insulin delivery, there are better outcomes, and similar factors have been reported for other systems in terms of prediction. So my response is yes, we can generalize these results, and this shows evidence of the superiority of automated insulin delivery as a technology. Yeah.
Thank you.
Thank you. Javier Castañeda Rojas, the time appointed for defending your thesis has passed. The degree committee will now withdraw to discuss the quality of your thesis and your defense. I request that you and your company await the results of our deliberations and our return to this room.
Please be seated.
Javier Castañeda Rojas, the degree committee here present has assessed the quality of your thesis and your defense. In view of its positive verdict and taken into account your previous qualifications, the degree committee has decided to grant you the degree of doctor. Professor de Galland is authorized to confirm upon you this academic distinction in accordance with Dutch university custom. I invite your supervisor to now take the floor.
Please all rise.
Okay. Do you promise to work in accordance with the principles of scientific integrity at all times, to be careful and honest, transparent, independent and responsible?
Yes, I promise.
By the authority invested in us by law, and in conformity with the decision of the committee here present, I hereby confer upon you, Javier Antonia Castañeda Rojas, the degree of doctor and grant you all the rights attached by custom and law. As evidence of this, I now present you with degree certificates signed by the rector, the secretary and the other members of the committee, and affixed with the official seal of the university. Congratulations.
Please be seated.
Dear Dr. Castañeda Rojas, dear Javier, it is a tremendous honor and privilege to be the first to officially congratulate you with obtaining your doctorate degree in medical science here at the University of Maastricht. I do this on behalf of your other supervisors, Dr. Cohen and Dr. Sander van Kuik. We are incredibly proud of what you have achieved with this degree. Oh, sorry.
Shall I start again? So let me say that it's a tremendous honor and privilege to be first officially congratulate you with obtaining your doctorate degree. Also on behalf of Professor Oliver Cohen and Dr. Sander van Kuik. We are incredibly proud of you, what you've achieved with this degree, and for what you've accomplished to get this far. With your research, you've clearly added important knowledge in the field of technology and diabetes. Moreover, you have made a significant contribution, or scientific contribution in this field, both at home and abroad. In other words, a truly major achievement. Your journey towards PhD began long before you actually approached us with this ambition to obtain a PhD. Through your work at Medtronic, you were already deeply involved in conduction of clinical research as a statistician. In fact, the list of papers that you co-authored was already so extensive, you could have easily made at least 7 thesis books out of them. From what I've understood, you called Medtronic's attention for your work during your master's degree at the University of Hasselt in Belgium, which you can integrate data analytics from medical devices. At Medtronic, you began providing advanced data analytics across 3 business units before, lucky for us, ultimately decided to dedicate these efforts to diabetes. At some point, the idea arose that it would be worthwhile to capitalize all the effort into obtaining a PhD degree. And since effective health, medicine, and life science of the University of Maastricht is nearly around the corner of Medtronic, or better we say Medtronic's at our corner, that seemed like the logical next step to realize this desire. So I think in the beginning of 2023, Javier first contacted Sander about this idea, and then Sander then in turn suggested to involve me because of the topic of technology in diabetes care. It was also a pleasure to discover that OHAD was involved in this project, almost from the start. I had already collaborated with OHAD in a large European-funded research project on hypocalcemia, in which Medtronic was also a partner. And while looking through your long list of publications, I also discovered that among the co-authors, many of them were well known to me. One of them was Pratik Chowdhury in the UK, a collaborator and dear friend. And because I didn't know you, I asked him about you for a reference. I'm not going to reiterate exactly what he told me, but it's suffice to say that he was exceptionally positive about you and your scientific competence. And indeed very supportive about the PhD trajectory. I think he even envied us a bit for not having been able to offer this to you. It goes without saying that if there were ever any doubts about you, this clearly put an end to them. And so we met for the first time in the famous lunch cafe in the hospital for a cup of coffee. Although I think by Colombian standards, this was probably more like a slabaki. You can ask your wife what that means. But irrespective of the poor quality of the coffee, and apart from a brief encounter at the ATD research meeting in Florence, Doswell's Coffee Corner became a regular spot for our meetings to discuss your progress. But if you thought that starting a PhD project in Maastricht was easy, even when you already had done most of the work, welcome to a lot of paperwork and bureaucracy, such as getting a master's degree from the University of Hasselt, being accepted by the university, and writing a decent TSP, that's a training supervision plan, and get it approved. When I look back at the process, I discovered we set the start date at March 1st, 2024, which we didn't make, and the end date exactly 1 year later. This was obviously a bit too ambitious, or to say, in your thesis jargon, a time too tight a range. It's worth mentioning that other than most PhD candidates, of course, you had to work a full-time job at Maastricht, you had a family to tend to, and quite a lot of traveling. Javier has many qualities. At Maastricht, you're highly valued for your diversity, your inclusiveness, and integration, combining rigorous academic thinking with industrial innovation that has led you to head a group of multinational talents. His work and unique insights have been truly translational, delivering tangible improvements in the lives of many individuals living with diabetes. Indeed, and that's what we found out during your defense also, even though you work primarily with enormous data for the thesis, you are aware of all the difficulties that having diabetes entails for people living with diabetes. Another of Javier's qualities, and one that I particularly appreciate as a mentor, is that he is a gifted writer. This was especially important for the writing of the introduction and discussion to complete the thesis, something that's often taken too lightly. But these building blocks are essential to cement a good and constructive connection between the chapters of the thesis. It was always a pleasure to receive drafts and revised versions of these chapters. There was perhaps a little setback after one of the committee members requested a broader view on closed-loop system, but you pick it up quickly by adding almost 2 pages on this topic. And all of this was always done with the warmth, the friendly politeness and respectfulness that characterizes the true Colombian that Javier is. But this politeness soon vanishes, I've been told, when Javier sees a dance floor. Then the friendly Colombian turns into a completely merciless dancer wanting to outdance competitors with the most complicated dance moves. So lucky for us, this was only a PhD defense and not a dance contest. Now the dance brings you to your family, because although knowledge makes one laugh, it's a well family life that makes one dance. I'd just like to extend my congratulations to your family here in the Netherlands and Colombia, to your wife Inge, and to your children Sebastian, great name by the way, and Thomas. You can all be very proud on what Javier has achieved today. Dear Javier, it was a pleasure working with you. I wish you all the best for your career and look forward to any future collaboration in diabetes research. Thank you.
Thank you so much.
Dear Dr. Castañeda Rojas, it's also a pleasure for me to congratulate you with this degree of doctor on behalf of the University of Maastricht and the Board of Deans. And of course, the university wish you all the best in your future career. So we are at the end of this academic ceremony. I will ask the audience to already go to the reception room where we can congratulate the new doctor. But before doing that, we will make a picture here in front of the screen in the aula. And after that, we will make a second picture on the stairs in the central hall, and also the family can join us. Hereby, I close this academic ceremony.